we talk a lot about myeloma, and for the most part, anytime anyone wants to talk about a cancer, everyone is really focused on stage, stage 1, 2, 3, and 4. In myeloma, we like to be different. We have 3 separate staging systems, but really when it comes down to it, probably the biggest determinant of outcomes for our patient is their genetic risk stratification. And for the most part, we stratified patients as either standard risk or high risk. There used to be an intermediate risk, but now we've kind of really separated the two. And it's hard to know exactly, but there's probably more around 2/3 of patients in standard, 1/3 of patients in high risk. The numbers are obviously changing. One of the things that I spoke about at ASCO was the variability of the definition of high-risk myeloma. And there's a lot of ways that we define it. And although the core group of definitions are cytogenetic, we include a variety of other modalities such as host factors, biologic things. So if we give you a certain course of therapy and the average remission is 2 years and you relapse in less than a year, you're functionally or biologically high risk, even if you don't have a cytogenetic marker. From a cytogenetic standpoint, we've had a lot of different ways of approaching this, ranging from the M-SMART guidelines, which is one of the key ones that's maintained by our colleagues at the Mayo Clinic, listing a variety of risk genetic profiles. The gene expression profiling, a lot of this was developed at the University of Arkansas with Dr. Shaughnessy. Some really great work has been recently done by Brian Walker and Gareth Morgan defining, double hit myeloma. So much in the way of the lymphoma world, using the concept of double hit and triple hit for multiple genetic aberrations that have high risk. We now have the same terms in myeloma, where we're combining things like 1q amplifications with 17p deleted or high-risk GEP patients. So there's a lot of ways of looking at the genetics, and the deeper you go, you probably find some high-risk feature. They appear to be additive, so it's not just having one high-risk feature is the same as having 2 or 3 or 4, but multiple high-risk features seem to add up to give us even higher risk. And underneath it all, we still use other factors of risk assessment, like age, frailty, response to prior therapies, performance status. So there really are a lot of factors that go into deciding high risk. And we're really also trying to enforce some degree of uniformity so that we can more accurately compare trials to trials. Because if we get 2 outcomes in 2 different trials looking at high-risk patients, we want it to be as applicable to the real-world patients as possible. And if this definition is different from that one, is different from the one we use at the bedside, it's not as useful as it ought to be. So a lot of work really needs to be done in unifying our definitions.